honored faculty and you all. Hopefully over the next 40 minutes, what I'm hoping to do is to give you an overview of nocturnal events, show you what parasomnias look like, show you what nocturnal seizures look like, REM behavior, disorder of arousals. In a sense, it's a nice tour. But what I really want to get across to you is that these nocturnal events are really a window to the brain, that sleep itself is a window to the brain and the brain's function. Much like what Dr. Pedley had very eloquently talked about in regards to the complexity of how the brain has temporal and spatial fidelity. It depends upon an array of genetics. Sleep, the state of sleep, increases that complexity. And with that complexity gives us an opportunity. So I want to thank Chris for inviting me. I want to thank our sponsors. I want to thank Dr. Pedley for being such a wonderful mentor and asking me also. And I want to thank you for the opportunity to speak, but also the opportunity to learn from you. So I hope you'll enjoy the next 40 minutes. These are my disclosures. Hopefully none of them will have any impact on what I'm going to talk about today. Thank you. So we're going to go through an introduction. I think, at least for me, one of the best ways to learn is by using some cases. And I'm going to have a case that we're going to walk through all of these areas and talk. We're going to talk specifically about disorders of arousals. We will go into the REM-related parasomnias and have primary focus on REM sleep behavior disorder. And then we will also talk about nocturnal epilepsy. So here's the case. It's a 42-year-old man that presented to me with a 6-month history of episodes occurring at night. These events lasted approximately 30 seconds each, where he would punch everything around him in his room according to his wife. He would make some unintelligible sounds and then go back to sleep. As far as he was concerned, he did not have any episodes, but these were very, very troubling to his wife. And so most of them, his wife was able to stay in the bed, but pretty soon she actually left the bedroom, went to a different bedroom because of the violence related to these. Typically, the events occurred in the first half of the night. He would have about 3 a week. Otherwise, really no medical history other than mild hypertension. He had been having some stress at work, typically would drink 1 to 2 beers after he got home at night to relax. And he was noted to have some light to moderate snoring. So I want to show you the event. This is his typical event. Great. That's the whole event. Really very brief, a lot of movement, and then it's over. No real appearance that he gets up or gets out of the bed. So this is a participatory lecture. You get to participate also. So what's the diagnosis that best describes this patient? A, he has epilepsy. B, he has night terrors. C, he has nocturnal panic attacks. D, REM sleep behavior disorder. E, sleepwalking. Or F, alien abduction. Anybody brave? How many of you think it's epilepsy? Nobody? Does anybody think these are night terrors? Okay, you? REM sleep behavior disorder or nocturnal panic? Sleepwalking? I won't ask about the last. Okay, so by the end of this, what I hope you walk away with, at least in this tour, 1, there's a wide range of behaviors. 2, we're going to talk about some key features that distinguish these events. Time of the occurrence and during the sleep period. Memory, yes or no for the event. The duration of the event, stereotypia, whether eyes are open or closed. And then hopefully, if you were able to capture them, some polysomnography features. The important points are really the key is in the history. And a good witness is absolutely a most important portion of the evaluation. Most of these are relatively easily treated, and then we're going to talk about timing. implication. So parasomnias are undesirable physical or mental phenomena, as we talked about yesterday. They usually have abnormal behaviors or complex movements, maybe. They may also include some emotions and perceptions. They approximately occur in approximately 3% of adults, about 15% of children. And when we think about parasomnias, we need to think in regards to state. We're all aware that we practice medicine in the awake state, but really our bodies go through at least 3 major states. We obviously have wake, but we also have non-REM sleep and REM sleep. And our physiology in each of these states is very different. In fact, it's down to the point that the amount that your kidneys excrete of potassium changes depending upon which state you're in. Your autonomic output changes. Your hormonal output changes depending upon each of these states. When we think about these states, we think of them as discrete. But when we get into the sleep laboratory and we have patients with these nocturnal events, we start to see overlap of these events. And so sleepwalking, night terrors, and confusional arousals, we start typically thinking of as an overlap with wake and non-REM sleep. These are areas that have both features of these sets. So we're going to start off in this realm. Non-REM sleep, as I said, is a different physiology. It's typically where we have decreased responsiveness to stimuli. Interestingly, we do not register any memory. We actually wipe out our memory. So if you happen to have students, college students, and they study and cram those last few facts just before going to sleep, don't really stay in the brain. They get wiped out. There's a mild retrograde amnesia. You can have visual imagery during non-REM sleep, although usually it doesn't have much of a plot to it. We typically see 3 types of non-REM disorders of arousal. We divide them artificially, and let me point out, artificially, sleepwalking, sleep terrors or night terrors, and confusional arousals. These, although we've distinguished these by certain features, these are really a continuum. They are the same type of event, the same type of pathophysiology, just extended across different behaviors. The key elements are typically that non-REM disorders of arousal occur in the first half of the night. Patients have no REM or no memory for these events. It's typical of non-REM events. They usually last minutes, so some can be quite long, but they're relatively short. They may be evoked by stimuli, especially stimuli that are occurring during deep sleep, slow wave sleep. The behaviors vary. They're not the same behavior each time. They're different. So when someone describes an event and then you ask them to describe the next event or the third event, you'll have 3 different types of behaviors with each event. The eyes are typically open and usually have less than 2 a night. Maybe 1, maybe 2 per night, but the frequency is relatively low. The peak occurrence is in early to mid-childhood. In fact, many of us who have children will remember these events occurring in 2 or 3-year-olds when it is actually at peak. And clearly the description is one of the key. As I said, this is an overlap of 2 states, a persistence. And in fact, what we see with non-REM parasomnias is that we end up having patients who wake, they get have a transition from stage N3, or slow wave sleep, and wakefulness. And really, in this disorder, what happens is part of the brain gets stuck in slow wave sleep, and part of the brain is allowed to arouse. These individuals are vulnerable to incomplete awakenings. Their brain does not make the complete switch from one state to another. And so there are parts of the brain that stay in slow wave sleep and parts of the brain that stay in wake. So when we evaluate these, we look for a clear description from the bed partner, we look for stimulating factors or provoking factors, and then we try to get some level of assessment during the attacks. Typically, these patients have slowed down speech, they're a bit dull, they may appear anxious during times, but they do not have complete interaction with their environment. When we look at them in regards to finding their events in the sleep lab, which sometimes we get lucky enough to capture them, we're looking for these 3 major patterns. And let me show you these 3 patterns. We may see slowing that continues throughout the arousal. Here's the central leads and occipital leads to the contralateral ear. You'll notice that they actual continuation of slow wave throughout the arousal. That's a very common feature where this distinction where you have alpha frequency on top of slowing. May see hypersynchronous slowing just prior to the arousal. And here's a nice set of hypersynchronous delta just prior to the arousal event. Or many times we can't see anything at all. We may see just artifact from movement. Let's see. So let's see what the behaviors look like. I'll show you a little variety. Typically, we do not think talking is a disorder of arousal. We consider it a normal thing.
You're snoring so loud.
This is a woman with non-REM parasomnias. She was complaining of her husband snoring. He was not in the same bedroom. Sleep laughing. This is a young boy who had multiple events of sleepwalking.
Am I sleeping? Am I flying?
You can see the behaviors are quite complex. Whistling. This young man actually had learned to whistle that day before. Young child with parasomnias, getting up, walking. This last story, we didn't catch walking, we caught scooting. Occasionally some bicycling movement. It's important if you are going to record these events or talk with families about the events that you talk to them about safety and how best to handle these individuals. The mother's actually in this room. This is a sleepwalker. Notice his eyes are open. He has a confused look about his face. But the mother comes over and is actually relatively quiet, calm. And that's an important point on intervening with these individuals. You do not want to be excitable. You can escalate aggressive events basically on how you're interacting with the individual. If you are talking in a low voice, you can many times convince these folks to go back to bed, back to sleep, and the event will be. It can be quite dramatic at the beginning. What signifies sleep terror is a scream at the beginning. The screams can be quite complex. Again, notice her eyes are open. And for many families, sleep terrors can be quite traumatic to the family. However, the patient is completely unaware of it. Sleep terror.
Take a sip. Yes, sir.
This is a prolonged one. Again, this is a good example of what not to do during a sleepwalking event. Start out as a sleepwalking. Mom is interacting, being very authoritative, and that actually makes the events become more aggressive. Here's another confusional arousal. And here's one that's induced by CPAP. The patient will go on to take the CPAP off. Completely and slowly. Be unaware. All right. So are these events red flags? I mean, after all, it's good video, it's wonderful fun, stories at social events. But the important point is that, yes, these are red flags. These are opportunities for us to make a diagnosis that is beyond just the simple event. And the reason these are red flags is for these individuals, they are vulnerable to transitions from sleep to wake. And so something is waking them up. And this is a red flag that something is causing multiple arousals during the night. And in fact, when you start looking for the causes of arousals, which is the real therapy of these types of disorder arousals, what we find is well better than half of the children that have parasomnias and sleepwalking will have sleep disordered breathing, and the majority of them improve after a tonsillectomy and adenoidectomy, and up to 40%, especially those that have had a history of sleepwalking and now it calmed down and now has come back. Many of those individuals will have sleep disordered breathing. And the parasomnia is the striking feature that announced the return of the sleep disordered breathing. So these are opportunities. Here's a case that's from ESPO, which shows progressive increase in esophageal pressure just prior to the sleepwalking event. And I think these are incredibly important for us to pay attention to. How do we treat these? Well, in general, we're going to educate families. They are relatively normal in age 2 and 3 years of age, but obviously as we get older, they become more disruptive. We make sure the room is safe. We reduce the causes of arousals. And many times, this is a diagnostic dilemma where you have to think and have the patient's family be the investigators for you. So I've had families who have I've asked them to go and sit in their child's room and listen around the time frame that the parasomnia is occurring, because there may be a clue. In one of my patients who had seen 3 other sleep doctors, never been controlled before for her sleepwalking events, what we found was what it started it out was a clock in the room below that chimed, and that would start her parasomnias. So it's a bit of an investigation. Sometimes it's the clock in the room, red light from the room, or a TV that's in the room, or a certain sound, an air conditioner. And those are the reasons that they're having the potential parasomnia events. Anticipatory awakenings, a scheduled awakening approximately 15 or 20 minutes before the usual event, done every night for 3 weeks, gives about an 80% chance of reducing or controlling these events. And we do that for 3 weeks, and then we let them roll. Interestingly, there is really no double-blind, placebo-controlled trial that shows efficacy for sleepwalking. But predominantly, what we do use are the benzodiazepines and occasionally the tricyclic antidepressants when we need to use these for therapy. There is a variant of this. It's called sleep-related eating disorder, which is different than nocturnal eating disorder. Sleep-related eating disorder is also a parasomnia. We typically think of it in the other category, but it also may occur as part of confusional arousals. And these individuals eat high-calorie foods such as raw hamburger, brownie mix, butter. Their typical behavior is during the day is very different than how their eating behavior is at night. They'll have no memory for the events. They typically occur out of slow-wave sleep. What's most interesting is that the therapy for this is slightly different. We know that topiramate, clonazepam, and codeine are all good therapies for this type, and I actually have had quite a few successes with topiramate. So the take-home points out of the non-REM disorder of arousals, these are really a mixture of non-REM sleep and wake. They're very not stereotypic. There's no memory. They occur in the first half of the night. The eyes are open. And typically we will need to look at these individuals in a sleep laboratory if the events are suspicious for another sleep disorder, or if that individual is at risk for hurting themselves, or there's something atypical. Many of them can be treated. We'll try to reduce sleep deprivation, other causes of arousals, such as sleep apnea or environmental causes. And we want to make sure that the goal is really that we avoid injurious behaviors. Okay, so let's go on to the next question. Recurrent distressing dreams associated with movement across large joints. Disorder is associated as an indication of disorder of arousals, nightmares, REM sleep-related seizures, REM sleep-related behavior disorder, or again, the alien abduction. Well, really this is REM sleep behavior disorder. So let's talk about features of REM sleep. We all know when we go into REM sleep, or we typically call dream sleep, we have very detailed visual imagery. In addition to that imagery, we have rapid eye movements, which gives the name of REM sleep. We have actually a registration of recent memory, and with that, we know that we actually have skeletal atonia. We are paralyzed during REM sleep. Our temperature control is no better than the average lizard. We are poikilothermic during REM sleep, so we lack any of that, but yet our brain temperature is actually higher. There are a wide range of REM parasomnias, including nightmares, sleep paralysis, terrifying hypnagogic hallucinations, cataplexy. We'll talk about just a few of them. Obviously, nightmares are complicated, frightening dreams. They may have a recurrent theme, and when they do, we many times may use dream imagery reconstruction therapies to work for these individuals, and they can be exacerbated by certain medications as well as psychiatric disease. In terrifying hypnagogic hallucinations, these are hallucinations that typically occur just as you're falling asleep or just as you're waking up. In hypnopompic hallucinations, they can be quite frightening. I have an individual who has visual hallucinations that the ceiling is falling in on her just as she's going to bed, or another individual who has an auditory hallucination just at sleep onset of a male voice telling her that she was going to be killed. They can occur in narcolepsy, but they can also occur in lots of other types of realms, and they are relatively easily treated with REM suppressant medication. Sleep paralysis is also a relatively wide occurring phenomena. In Canada, it's called the old hag syndrome. In Mexico, it's called the dead body fell on me syndrome. These are episodes where you're paralyzed, you can't even move your fingers, can't scream out, usually lasts a few minutes and then clears. Again, if they're recurring and distressing, we may use some sort of REM suppressant. However, the real one that I want you to pay attention to here is REM sleep behavior disorder. And these are individuals who enact the dreams. Their events can be frequently violent, and the patients have typically good memory recall for these events. They are very short, usually seconds. They occur multiple times during the night, and the events are not stereotypic. In other words, it's not the same event each time. Their eyes are closed, and they're more common in elderly individuals. However, I will tell you that one of my very first cases was actually a young girl who was sent to me at age 13 who actually broke the cricothyroid of her father. When he bent down to give her a kiss, she was dreaming that she was being chased by a bear. And she turned, grabbed the bear around the throat, and pushed her thumbs in. Unfortunately, that happened to be her father, and she fractured his cricothyroid. And she was sent to me for obviously nocturnal violence. What we look for is actually excessive muscle activity. And what I want to point out here is this is REM sleep, rapid eye movements, low fast EEG, and low tone in the chin. Notice the chin is relatively flat throughout here. However, extensive leg and arm EMG activity during this time. So let's look here at the video. Show you some events. So I want you to notice some relatively quick events, reaching events. Quick. Right in here. What's interesting is a lot of these very short, quick movements are characteristics of sinuphreniopathy. In our older folks, we're going to see more quick movements, especially with long activity. The gentleman who's dreaming is going to the end of the bedroom and now trying to push the chicken out of the door. This is a professor dreaming that he's giving a lecture and having a haggling. One of the students is coming up and haggling. And this was a policeman. I want to point out, he said, "Watch yourself, David." He has a gun. He's going to apprehend the suspect. And then quickly put them under control. So they can be quite violent, which is the most important point to remember. We really try to work to try to keep these families and bed partners safe, as well as the patients. It's an important distinction to make the diagnosis of REM sleep behavior disorder, and I want to point out that there are two major features that both have to be accompanying together to make this diagnosis. So you have to have the REM sleep without atonia that's found on the polysomnograms, so demonstrating that during REM sleep they have excessive EMG activity. You also have to have the dream enactment behavior, so a history of dream enactment or catching major events, such as the ones that I just showed you, the gentleman kicking the door, or kicking the person out the door, the lecturer, or the policeman, to act out the dreams. And those together, only when you have those together do you actually meet the diagnosis for REM sleep behavior disorder. Dream enactment by itself does not make the diagnosis. REM sleep without atonia does not make the diagnosis. So it's together. And the reason for this is actually in the brainstem, there's quite a complex network from the subceruleus nucleus to the medullary atonic center that ultimately results in the release of glycine at the spinal cord anterior horn cell that produces our atonia during REM sleep. And it's impairment of this network that is really what is showing during REM sleep behavior disorder. What's interesting is this network is selectively vulnerable. And what we see is that features that may disturb REM sleep or certain degenerative disorders may affect this network decades prior to the involvement of other noticeable or applicable components of disease. And so we see this in the synucleinopathies, as we talked about before, but also in narcolepsy. And this is one of the most common reasons for patients to have REM sleep behavior disorder, but also in other structural issues of the brain and brain stem. It is associated with a degenerative disorder, especially in our elder population. We know that the synucleinopathies, Parkinson's, Lewy body dementia, and multisystem atrophy are the most common. And as we look across a 5-year period, what we see is that the number of individuals that remain free of this degenerative disorder slowly declines, so that even by 10 years out, approximately 2/3 of individuals have developed one of these features. There are some other neurological dysfunction in patients with idiopathic or early idiopathic REM sleep behavior disorder. These individuals also have other features that are very consistent with synucleinopathies, although I will tell you this is also present in the patients with narcolepsy that have REM sleep behavior disorder. They may have a decreased sense of smell, they may have a mild decrease in visual spatial discrimination, and they all have decreased cardiac sympathetic outflow, which is an important component. So how do we do the workup? What do we really need to do with these individuals? I think one of the important pieces is to not pass them off. Don't let them walk out thinking they're crazy. These are typically normal individuals during the day. They're perfectly fine. If you do a neurological exam, you most likely in the idiopathic form may not be able to pick up much in the way. Many of them, though, will have features of Parkinson's or REM sleep of multisystem atrophy as they've progressed. We do need to get a good, careful history. We do need to do a complete neurological exam, specifically looking for features of synucleinopathies or brainstem issues. And we need to do a sleep study. And if possible, we may look for structural lesions on an MRI. When we're looking at goals of therapy, somewhat different than the therapy in epilepsy where we're trying to have complete resolution of seizures. In REM sleep behavior disorder, we're unable to get to the goal or having complete resolution of all movement at night. The major goal is to prevent injury. So minor movements are going to continue despite therapy. And our mainstay of therapy is clonazepam, but a second-line therapy is melatonin. And I think it's important to recognize that, at least in the United States, about 40% of the bottles of melatonin on the shelf do not have melatonin in it at all. So you want to make sure that you're using a brand that actually has melatonin in it. Sometimes donepezil may work, clonidine, and pramipexole. So the take-home points from the REM areas: 1, REM sleep behavior disorder potentially violent. The diagnosis should be made not only by history, but also with video polysomnography. We are going to look for a majority of these individuals to develop a degenerative disorder process down the road. And the main focus is going to be on safety. And we follow these patients along. There are other parasomnias. And yesterday we saw a great example of cataphrenia. I want to spend a couple moments on exploding head syndrome. So here's the question. What is the most prominent symptom of exploding head syndrome? A, an explosion noise made by the patient. B, a loud bang heard by the patient. C, pain in the head of the patient. D, enlargement of the patient's head circumference. Or E, a mess to clean up. Well, the answer is actually a loud bang heard by the patient. And in fact, this is a very rare, relatively rare issue that comes up, but it is completely benign. These patients hear a very loud or imagined noise. They may even have the sense or the feeling, the somatosensory portion of an explosion occurring near them or around them. It's more common in women. It occurs at all ages, and it typically occurs in stage 1 sleep. The important point to remember is it is completely painless. There is no pain associated with it. So if you're hearing the complaint of pain, that's something different. It is not exploding head syndrome. It actually does improve with topiramate, and we've reported that and certainly had great experience with resolution with it when it's recurring. Okay, so let's move on to nocturnal seizures. So approximately 20% of patients with epilepsy have seizures that are strictly while asleep. And I think what Dr. Pedley did in setting up, talking about epilepsy was wonderful, because in talking about the complexities of how we are viewing our epilepsy patients, and what the genetic features are that are bringing up or predisposing, many times we may find that state actually predisposes certain networks to be more epileptic. And I think that's a key. We know that seizures typically occur during non-REM sleep, that REM sleep itself is actually protective and may actually be therapeutic. A greater amount of REM sleep at night may reduce seizures during the day. We know that they're more commonly going to occur in the frontal and temporal regions. And the key element that I want you to walk away with is that the events are stereotypic. In other words, it's the same behavior each time. Now granted, the postictal behavior may be different, but the initial behavior should be stereotypic. You might also recognize that most of these individuals, their daytime EEGs will be normal, whereas the nighttime EEG during sleep may be where the real action is. And these type of individuals typically respond better to medications than the diffuse epilepsies. When we think about the stereotypic, that is the feature that is most important to recognize. All of these behaviors can occur during seizures at night. In other words, there is no single behavior that tells you this is a seizure. Patients may rock, they may have vocalizations, they may use one extremity or another, they may have jerking, they may have very complex behaviors. And I'll show you some complex behaviors. But the important point is to recognize it's not the behavior itself, it's the fact that the behavior is stereotypic. So let's look at a couple of these. So this is a gentleman who was sent to me because he could not sleep with his wife. His wife said, what you see is his arm comes out, and he would typically push his wife out of bed. And so this was the reason that he was sent to the sleep center. As far as he was concerned, he was fine. He just felt he had cramps, and that was it. How quickly they occurred. Gentleman actually went on to have ribs, he had supplementary motor seizures, and actually refused surgery. Even though he had ribs. Here's another frontal lobe seizure with quick honk. You're going to see they occur. These actually occur very quickly after arousals. So kind of a Dracula position, arms up, flexion. Here's a gentleman with CPAP. This is why we always have seizure precautions in the lab. This is a gentleman that's on CPAP, and you can see his seizure. He's actually confused, posturing the foot, and he's out of bed. Here's a lady who was sent to me for, actually out of a DSS, or Department of Social Services, screaming at night. Here's another gentleman with screaming and vocalizations. And this is a gentleman who was sent to me for sleepwalking, but I want you to pay attention to the fact that this is his behavior. He sits up. He has no memory for these events. He has this kind of little rocking back and forth. put the bedroom on. Unusual breathing. Then he turns TV on. He has no memory yet. Here's another thing. Same type of seizure. Same night. Same rocking. Stand up for the head. So the history can be quite complex. Third, very quick, subtle arousal. There are certain well-recognized syndromes that are epileptic syndromes that are associated with state. We know that benign Rolandic or benign childhood with centrotemporal spikes is actually well known, and Dr. Pedley just talked about that a little earlier. Autosomal dominant nocturnal frontal lobe epilepsy is also well described. We'll talk about that just a little bit more. But many of these that are state related are focal. Many of the awakening epilepsies are primary and generalized, and there's also an unspecified type of continuous spike and wave in sleep. When we think about autosomal dominant nocturnal frontal lobe epilepsy, these are individuals who have inherited a form of epilepsy, an autosomal dominant form, where they have quick arousals, very hyperkinetic events. Many times they can be brief and violent. They may actually have tone or verbal outbursts with them. Their daytime EEGs are typically normal. And even during the spells, many of them may have no change on the EEG during the brief events. A family history is often very difficult to obtain. I found in talking to individuals that follow whole cohorts of these, they have to question individuals multiple times. And about 1 in 4 will actually have a daytime seizure. Most of them don't. Here's a typical EEG. We can see from sleep a rhythmical pattern occurring in the frontal head region. And that is if you're lucky enough to actually capture EEG change. What's very interesting about this is a genetic disorder that actually affects the nicotine receptor as a channelopathy. And what's, I think, remarkable is the fact that it is state-related gives us a good clue into thinking through how would a nicotinic receptor be vulnerable to activity or overactivity during sleep. And this is one of the times where sleep offers the opportunity to have selective hyperactivity or overactivation of one select receptor. And this is what happens in autosomal dominant nocturnal frontal lobe epilepsy. So we have this nicotine receptor channel being overexcited with minor arousals, and that actually provokes the seizure. We look at the receptor complex, what we see is that although it's a sodium, typically sodium and minoling calcium, we actually have multiple different forms of the same receptor being changed. And the fact that we know now that the Australian, Japanese, Spanish, and region types typically work are all different mutations on the alpha subunit, and our Italian family and Scottish families are on the beta subunit. So in wrapping this up, let's look back again at our case. Again, there are lots of keys in this history. We have a 42-year-old male, so not a young child, middle-aged. Events that are lasting by family history or by family's history 30 seconds, but we see they're relatively brief. He punches everything around him, so they're relatively stereotypic, but he has no memory. They occur in the first half of the night, and he has a frequency of about 3 per week. So if we take a look at this event again, and when showing this to the family said, yes, that's exactly the event. He does that every time. So what did our original patient have? The he had these key elements. Did he have a non-REM parasomnia? Did he have a REM parasomnia? Did he have other parasomnias? Did he have nocturnal seizures? Any votes? No, he actually had nocturnal seizures. These are nocturnal seizures. And that's the key. The sleep actually gave us the opportunity there. So I'm going to slide going through this. So hopefully I've given you a good opportunity to look through a wide range of nocturnal events and how these events can present in regards to the time of the occurrence, whether they have memory for the event, duration, whether the events are stereotypic or not stereotypic, eyes opened or eyes closed, features. And I hope that in summary, you're able to see that really sleep is an opportunity for us to examine the brain in a unique way that we don't typically see when we're examining patients in the clinic. So thank you very much, and I'll be happy to take questions.